I'm just going to have it a kind of interactive session, and it's going to be only one case I'm going to discuss. This, of course, may be relevant to you all because we used to come across almost every day, right? This is a short history. 40-year-old gentleman coming with some chest pain with some short of breath over last one hour duration. Otherwise, he is clinically stable. And there was no major risk factors for coronary artery disease as well. So, as a routine, the patient has undergone these sets of investigations, including troponin. It came as slightly positive. So, this is on admission ECG. So, this is a ECG. Any thoughts of this ECG? Anything, any abnormalities, first of all, you can see on this ECG. There are some widespread ST elevation, but ST elevation, it's not a typical ST elevation either, right? So, what is your thought of here? What is a possible diagnosis or differential diagnosis you might think of? Acute pericarditis is possible here. Now, yeah, so this is, of course, acute pericarditis. And I'm just going to, you have to go through in detail of this chest pain. This is the most important here. That's what I want to highlight as well. Because this chest pain is not typical as you get in angina, right? So this is a pain which is maybe pleuritic, sometimes worsen with lying down or supine position, and which relieves with bending forward. So these are typical. And even sometimes you might not get a typical pain sometimes, right? So these ECG abnormalities, and how are you going to manage now? Now, before that, this is the changes of the pericarditis changes on this ECG. You might not get all the time. You might not get ST elevation, right? Sometimes you might get widespread T inversions also, right? And there are some kind of evolving changes as well. You might see, right? It's not typical as in acute coronary syndrome STEMI. You might get sometimes ST elevation, sometimes ST depression, especially if you look at carefully the PR segment. This is important, right? PR segment is depressed PR segment, right? Now, these are the two major things you have to keep in your mind while you are interpreting this kind of ECGs, right? First, you can see the J point elevation in these ECGs, right? So, but it's rarely exceeds more than 5 millimeter, not like in STEMI cases, right? And also it's widespread, it's confined to the coronary artery territories. That is another key, you have to know that. And there was no ST segment reciprocal changes, as my previous speaker said, that in STEMI, you will have evolving changes with time, which is typical to the ischemic changes. And the other changes like concurrent ST elevation or T wave changes is very rare, and also is PR segment changes. You can see depression of PR segments, right? So these are the important features when you look at this kind of ECGs, especially when a patient is coming with a chest pain. First thing is you have to analyze thoroughly about the chest pain and this ECG. Now, where you are sometimes misguided because of this troponin, right? That is what I want to highlight here, because when you look at this troponin results, you are reluctant to send the patient without loading dual antiplatelet, even sometimes anaxaparin, right? Because what you do is, for the marginal troponin, you should know while interpreting this troponin, this acute coronary syndrome is not the only case you will get this high troponin, right? There are a lot of other conditions can give rise to raised troponin, but is very mild, sometimes even less than 1,000 most of the time, right? So, for example, like this here in pericarditis and chronic kidney disease, pulmonary edema, and other ongoing infection, all can give rise to raised troponin, right? So you have to always keep in your mind while interpreting the troponin, because we used to get some referrals. So this kind of scenario is coming with the pain, chest pain, and troponin, positive troponin. What to do now? right? You have to interpret now thoroughly, and before requesting the troponin also, you have to have in your mind that you are going to get this kind of troponin, right? So just make sure that just to show the difference between these ECGs, this is right side, you can see the typical ST elevation ECG, STEMI cases, right? You can see anterior STEMI with some reciprocal ST segment depressions in the reciprocal leads. And you can see the STEMI and, sorry, the normal ECGs and acute pericarditis. Now you can see the difference, right? This is a previous one. You can see the STEMI ECG, and this is the acute pericarditis ECG, right? Okay, this is again, I'm just putting this slide to compare these two. Right, now coming to the diagnostic point. Now you do, first you do a thorough history about chest pain and do the basic investigation. One thing is you have to do the serial ECG, the reason why to exclude ongoing any acute coronary syndrome. Another one is you can see this will confirm with the pericarditis as well. In the meantime, you have to look for the causes to find out what are the pericarditis, right? So in basically inflammatory markers, X-rays, and basic bloods you have to do. And these are the common causes ends up with this pericarditis, right? So mainly is the infectious causes, and even post-MI patients, because that is another scenario we come across after following STEMI, patients end up with the pericarditis, and again you have to interpret that from the history and the other blood investigation, right? Right. So how do you manage now? Of course, you have to treat the etiology, and you have to give some pain reliefs with analgesics, and you have to control the inflammation. Right. So these are major three things you can give a treat with the NSAIDs, colchicine, and in resistant cases you can consider steroids. Right. So you have to give aspirin, but fairly higher doses of aspirin, and you have to continue up to the pain-free for minimum of 20 hours, 24 hours. So this is about colchicine. You can give, in addition to NSAIDs, you have to give at least for 3 months. You can go for this dose of 0.5 to 0.6 milligram. If it is more than 70 kilos, so if it is less, you can give this once daily dose. So steroids, as I mentioned to you, it's mainly considered to give those who are resistant for those NSAIDs and the colchicine. So this is algorithm we can follow this, right? Now, this is about the kind of case we used to come across almost every day, right? Now, I'm going to run through some few slides, which we are not supposed to miss those ECGs, right? My previous speakers and highlight was that, but I want to show this. This is one thing, right? This valence pattern of ECGs, because the last during the on-call I'd seen about 3 cases which were missed, basically this valence pattern of ECGs. They came with a chest pain, bit of sometimes an atypical kind of chest pain. They was given a bit of aspirin and home back, and again the following day they came back with a ongoing pain. So when I saw the patient, it was typical valence patterns of ECG, and I did the angiogram. It was critical proximal LAD, because it is important, because LAD, you all know, the left anterior descending artery is it's most important in terms of your mortality and morbidity benefit point of view, right? You don't want to miss it, right? This is one kind of ECG, valence ECG. So you can see that there's only very minimal changes especially in the anterior leads, right? So biphasic T's, right? If you had a slight doubt, these kind of patients, sometimes they don't have a positive troponin as well. So if you do troponin, if it is negative, you tend to discharge without any proper follow-up or proper guidance, right? So they are ultimately end up with massive anterior STEMI. Even some patients are dying, right, because of that. So this is another pattern of valence ECG. Right. Again, this is another one. This AVRST elevation. This is already my previous speakers were talking about this. This is also you are not supposed to miss, right? So AVRST elevation is more than 1 millimeter. And especially with in addition to that, the V1, you have to look at carefully both AVR and V1 with a widespread ST depression. It's more than 6 leads. If you see, you have to be very alert of sending these patients for early or urgent is better. This is the typical ST elevation AVR. You can see the widespread ST depressions. And the other one is De-Winter syndrome. Again, Dr. Kapurth mentioned about this. This is again less common, but it's very important to pick it up, right? So again, this one, if you see this kind of ECGs, this again tells you it's a critical left anterior descending artery disease. You are supposed to go for intervention as early as possible, right? So please don't miss these kind of ECGs, right? Okay, right, all right. Thank you.